Bueno, John Bueno lecture. Give you a few comments about John Bueno. I think most people in the room probably don't know who he was. John was a faculty member here at the Medical Center from '84 till his death in 2011. And he's known internationally as a pioneer in arrhythmia research, and was there at the dawn of our specialty, electrophysiology, and actually developed a basic science lab mapping cardiac arrhythmias. And he's best known, I think, for, at least in my mind, for his contributions to the treatment of arrhythmias, starting with Wolf-Parkinson-White syndrome, which was treated surgically for the first time at Duke University, where he worked. It was actually a few months earlier a case at the Mayo, but I'm told that it wasn't successful. And the remarkable thing about, John had an anecdote about this. They had suspected that Wolf-Parkinson-White was mediated by a pathway, but the Kent bundle, if you know anything about the history of the EKG, and we'll hear a lot about that from our speaker today, Kent proposed in 1915 that the accessory pathway was actually just a dissociated piece of the AV node. So there was no histological demonstration of an accessory pathway until a veterinarian at Penn, Dr. Miller's alma mater, brought a dog that had Wolf-Parkinson-White down for mapping at Duke, where Dr. Bueno had established his laboratory, and they mapped the animal and then did histology and got, for the first time in the world, histological evidence of a pathway, of what a pathway looked like. And later, John also participated in demonstration of the importance of the border zone of an infarct to provide an area of slow conduction that was critical to the formation of ventricular tachycardia. When he came here to the university in 1985 with James Cox, they collaborated and developed the Maze procedure, which remains the gold standard for a durable cure of atrial fibrillation. And that work was all done in animals to develop the lesion set that became the Maze procedure, and continues to be an area of active interest both in cardiac electrophysiology and in Dr. Damiano's laboratory. This conference, I should say, is co-sponsored by the Division of Thoracic Surgery and Division of Cardiology. John was a member of both divisions and biomedical engineering as well. And the spirit of this lecture and in John's memory was to commemorate that collaboration between surgery and medicine in the history of cardiac electrophysiology and the understanding of the pathophysiology of arrhythmias and the development of the treatments. So it's my great honor to introduce our speaker today, the Bueno lecturer, Professor John Miller from the University of Indiana. Dr. Miller is an apt lecturer for the commemoration of John's spirit, certainly. At the beginning of Dr. Miller's career, he was part of the group at Penn where Mark Josephson, who's arguably the most famous cardiac electrophysiologist in the modern era, where he trained and developed surgical techniques for the treatment of ventricular tachycardia. Dr. Miller then went on to become ultimately the head of the program at Indiana, where he's trained generations of electrophysiologists, and throughout his career has remained really at the cutting edge of cardiac electrophysiology and mapping and the understanding of arrhythmias. And he's also distinguished himself as a teacher of generations of the fellows that have trained with him as a director of the fellowship training program, but nationally through lectures that he's given in fellowship programs, and then through the ABIM maintenance of certification, where he's been the chairman of that for several years. So it's my great honor to welcome John Miller to lecture today.
Thank you, Dr. Faddis. Thanks for the background about our named lecturer, Dr. Boineau. We'll talk about him a little bit. It's a great privilege to be here with you today and to share some recollections and insights as to the nature of the electrocardiogram. This is a story of collaboration and innovation, invention, and it tells a lot about working together, and that's what we still need to do nowadays, not people in their silos doing their own thing, but working together. So those are my disclosures. I want to start off talking about this young lady, Jean-Louise Calment. She's a very attractive young lady. This is when she was 20. This happened to be around the same time the first electrocardiograms were done, when this photo was taken. We'll come back to her. You see, she was born in 1875. The ECG had humble beginnings. Willem Einthoven, a Dutch physiologist and physician, is regarded as the father of electrocardiography by most, and rightly so. He really took an interest in the heart rhythm from an early age as a physician, and developed some technology and just stuck with it for years and years and years until this thing became perfected. There was a great foundation on this. Giovanni Volta, Galvani, Matteucci, several others had all contributed some insights into the electrical activity of the heart. It not only generates electrical impulses, but it responds to electrical impulses. You can shock a chicken and then things will happen. So all this experimental stuff was done and written, and you see, it goes back to the 16th century with some of these guys. A fellow named Lippmann in Britain developed a thing called the capillary electrometer for completely different purposes, but it was capable of recording really, really tiny voltages and amplifying them. And that was in the 1870s. That was parlayed some years later by another Britisher named Waller, and he used this electrometer to record an electrical signal from the limbs of his bulldog, Jimmy, who somehow he got to stand in 4 buckets of saline. I don't know how my dog wouldn't do that. And as well as a person. We don't know the person's name, but this was a lead that was on the front and back of the person. I'll show you an example of that in a second here. Einthoven attended some of these lectures and said, oh, we can do something with this. He used the capillary electrometer, but then transferred to another technology called the string galvanometer. This was where you put a very thin string coated with silver with input from above and the other limb on the other end of the string galvanometer, and have 2 huge electromagnets, and whenever there's a little tiny voltage, it passes through the silver coated string and has a little deviation. You can shine a very bright light on this and project it across the room so you can see it waving instead of just little tiny oscillations there. But he made some improvements on it. I wasn't happy with the current technology, so he went further with this. So here's a capillary electrometer. This has a little blob of mercury up here and a very thin capillary tube, and then a bath of sulfuric acid down here. There's a potential difference between those two. And when you send voltage on input from one arm, for instance, to the other arm over here, it causes a little bit of oscillation in the meniscus of that mercury, and you can record that. And this is what it looks like here. Well, it kind of looks like an EKG. It's, you can sort of make out some stuff there, but it's a repetitive electrical signal. Now, Einthoven was not happy with this. He got this to be a finer and finer filament, and whereas Waller had resolved just a couple of, he said there's a V and a V here, that's what he called them. But Einthoven says, no, there's actually 4 different deflections here, and there they are, A, B, C, D, and that's how our ECG started, not PQRST, but A, B, C, D. But then he was a brilliant guy. He did some mathematical modeling and said, if we had an infinitely small, infinitely unmassive filament in there that had a perfect frequency response, we would see something much less damped than these are. So here we see the ABCD as up here, but his mathematical modeling turned into this thing that looks an awful lot like an ECG. This is not a recorded, this is mathematically modeling back in 1900. So he renamed them PQRST because we'll talk about that in a second. So here's this famous picture. This isn't Einthoven, this isn't one of his patients. This is some guy. This is from the Cambridge Scientific Instruments Company in 1910 or something like this, way after he built his. But this is a crazy thing. You got this string galvanometer in here, the electromagnets, it's projected over here. You look at it in this microscope thing. It's not portable. We'll talk about that in a second here. And this is actually the first machine. And you can see this is just kludged together. Give me a stand here. We need to put this on top of something and move it around here a little bit. This is just office furniture that they've kind of tied together into something that have to align everything, crazy stuff. And here's one of the first ECGs, 1903. Doesn't look too bad, comparatively. It's pretty good. Now, he made a lot of contributions to the ECG. There he is in his later years. He improved the capillary electrometer, transitioned to the string galvanometer to improve its dynamic range and its frequency response, and was the first to remotely record an ECG. His lab with that machine, it's not portable. And they had a patient in the hospital a mile down the road in Holland, and just ran some telephone wires and recorded it. So that's nothing new. This is 1905. He standardized the nomenclature that we still use today. It was originally, we'll come to some of that in a second here, but it goes to PQRST. Standardized the format. The ones that we use nowadays, the 25 millimeter paper speed and the grid amplitude, those are all from Einthoven, way back when. He described in 1906 some ECG abnormalities that, I mean, he inferred a lot of this was going on. He couldn't see the heart action, but he could see the effect on the ECG and inferred a lot was going on. He expanded to 3 leads and paired the paired limb leads that we currently use, 1, 2, and 3 nowadays, and began the study of vector cardiography. It's kind of gone by the wayside nowadays with some other technologies, but had its day. For these contributions, he was recognized and won the 1924 Nobel Prize. He was still fortunately alive to accept it. Now, a little bit of alphabet soup here. Here's the capillary electrometer I showed you earlier. Waller called them V1 and V2 because he was a physiologist. He thought these were both deflections from the ventricle. Maybe it's contracting twice. Einthoven called them A and B. And then it got more complicated when I showed you this the derived modeled ECG previously. So with better resolution, he said, you know, we can't call them A and B and stuff like that. We'll just throw all that stuff out. We'll call them PQRST. Started after Descartes with P as a point on that curve and went from there. So we recognize this nowadays as the PQRST. Don't forget the U wave there as well. It has its own story. We won't come to that today. But there's other letters that have been associated, other names have been associated with the ECG. Everybody's familiar with the delta wave. Why is it a delta wave? Well, it looks like a delta. It's a little triangle in there. And then after that, you get epsilon. So there's epsilon waves on the ECG, these little tiny ripples here at the end of V1, seen in arrhythmogenic right ventricular dysplasia, cardiomyopathy. And then there's J waves. There's a whole syndrome about J waves, early repolarization. A lot of folks have it. A lot of folks have early repolarization, and a few of them have real bad problems with it. We'll come to that after a bit here. And then an exaggeration of this, when you get really, really cold and your QT interval goes along as well, is the Osborne wave, and described in the 40s. Now, 3 major personalities come along here. There was Einthoven, Lewis, and a guy named Wilson. So Thomas Lewis was a great proponent of the technology and researcher. Here he is with Einthoven in 1921 in London. They were good friends, collaborated well. He got himself a string galvanometer too. It was actually loaned to him by the first manufacturer, the Cambridge Scientific Instruments Company. And he said, let's improve on this a little bit. And he did does anybody recognize the words Lewis lead? Well, I've used them from way back. And this is basically taking the lead 1, the arm leads, and moving them around on the chest until you get a good-looking P wave. He invented it. This is the Lewis of the Lewis lead from way back when. He really dominated the field in the early days and wrote these 3 books. These are not papers. These are books, 1 year after another. I can barely turn out a major paper every year or a chapter, something like that. But he's a busy cardiologist and doing all this stuff. He was the authority back then. Here's some of his tracings here. We recognize this nowadays. It's pretty slow atrial flutter. He calls them P waves and R wave in there. It's pretty insightful stuff. But At about 1920, he said, you know, this has been fun, but I think the ECG's done what it's going to do. We can't learn anything else. So he went to peripheral vascular disease. Nonetheless, he had popularized the field so much that in his acceptance speech at the Nobel meeting, Einthoven gave Lewis credit for his being there. Comes along Frank Wilson. He's an American. He was in St. Louis for a while, actually, after the war, World War II. And he went to the University of Michigan, where he became head of cardiology there, sought to extend the utility of the ECG. He was one of Lewis's pupils. They had collaborated during the war. I think it was World War I, actually. And got interested in the ECG. And he devised a unipolar exploring lead. So it's not technically grounded to anything, it's just kind of floating. But it's on the chest wall because he said, okay, we got the limb leads, but let's look at the horizontal plane as well, see if we can get any information there. And in fact, devised an array of 6 precordial leads that could be used. We use those nowadays. So the ECG goes from the 3 arm leads and the ground on the other leg to the 6 precordial leads. We got 10 electrodes nowadays, and they represent 9 recordings on the ECG. He also figured out a way to be able to get a kind of a floating ground. It's called the Wilson Central Terminal. He tied the limb leads together, put in a 5,000 ohm resistor, and you've got a pretty clean signal that we have nowadays. So the precordial leads became the standard from then on. He evaluated a lot of the abnormalities of the QRS complex with which we're familiar nowadays. He was so famous that he actually had visits from across the ocean. Both Einthoven and his wife, and Lewis and his wife, came to Ann Arbor to visit him. There's a famous picture of Einthoven sitting with a cottage in the background when he was visiting in Ann Arbor. The early ECGs, this is one I showed earlier here from Einthoven in 1903. It's not too bad, actually, but it was obviously limited in its scope. You get 1 recording, a bipolar limb lead, noisy signals, cumbersome. You can't drag this around very easily. You have to have a pickup truck or a lorry of some sort. That's Lewis's I showed you earlier. This is from Frank Wilson in 1915. Again, it's pretty noisy. Here's PVC. He identified that correctly in there. This is some more of his work, and he called leads 1, leads 2, and lead 3, and lead 4 was his exploring lead on the precordium. And you see that this person here had some pretty profound ST depression that got better, and 3 weeks later got better still. So he showed the value of serial recordings in an ECG as well. Now, here's our modern day ECG. This is beautiful, right? Nice clean signals, high fidelity, good frequency response, a little sinus tach. We'll come back to this a little bit later here. When everything goes as it's supposed to, I tell my fellows in a procedure, they go, wow, it was a great case. Everything went just perfectly. And I said, and what did you learn? You learned nothing. You learn the most when something doesn't fit. And I tell my fellows, always ask the question, what's wrong with this picture? Because sometimes that's very important. Your electrode is, you've perforated or something like that. You need to be able to you need to answer that question, not just say, oh, it'll probably be all right. You need to answer that question, move on. And it may be a pearl in there that you've never seen before, or maybe nobody's ever seen it before. So in the early days of electrocardiography, and still today this is happening, as we'll see, recognition of an abnormality is the seed of investigation and innovation. To recognize an abnormality, listen, you have to know what normal is, right? If I hand Millie a $20 bill, she can recognize it as a $20 bill. If I hand you a 1,000 lira note, maybe it's real, maybe it's fake, but you can tell if it's real or not. So you have to have enough of a library of experience to know what normal is, and then you can say, that's abnormal. That doesn't mean it's bad, it just means it's abnormal. But that's just the start of things. You have to say, is this a variant of normal, like a lot of voltages, normal heart, but left ventricular hypertrophy, or is it something that's really different? And then you make hypotheses as to why this should be, and then you test those hypotheses experimentally in a laboratory setting, make a laboratory prep that mimics what reality is. You can look at experientially, look at other folks who have the same abnormality and see what their outcome was, kind of the reverse of AI. And you can do modeling as Einthoven did way back. This is all going on nowadays in all these fields. And so with these methods, new disorders are discovered and characterized, and new therapies can then be devised to help folks. That's what we're all afterwards. Okay, so you get hypertrophy, long QT syndrome, Wolf-Parkinson-White, Brugada syndrome, a host of other things. Ischemic changes, those all had to be investigated as to why they occurred. We recognize it, it's an abnormality. It correlates with this, it correlates with that. So let's see exactly what this is due to. Once enough normal ECG material had been obtained, it was clear that some people were not in that group. You might have more P waves and QRSs, that's heart block, very fast rates, tachycardias, premature complexes that might be atrial or ventricular, very large complexes for hypertrophy in the right or left ventricle or the atrium, very wide QRSs, bundle branch block, and things that look like bundle branch block. And enter this trio here. Anybody know who these are? Wolf, Parkinson, and White. This is the only photo of them all together. This was after they had collaborated and came up with this publication in 1930, the American Heart Journal, where they described bundle branch block with a short PR interval in healthy young people prone to paroxysmal tachycardia. It was an observation. They talked about, I've got a few patients that have this weird stuff. Hey, I've got some of those too. None of them had enough of themselves to be able to put anything together. But when they collaborated and got their heads together, they said, you know, we got something here. And I don't know how many were contributed by which, but they had about 20 or so patients. Here's one of their ECGs. Not the best, but it's clear that there's pre-excitation here and there, and then we lose pre-excitation. What they said was spontaneous reversion from bundle branch block curves to normal ones. That's the best they could tell. That's the model in which they're trying to fit things. And then it took some other folks coming along a little bit later to try to figure it out. There were probably 35 or 40 different hypotheses as to what this was all about. And this one was before there was any histology of these things, before there was any recordings of pathways, but this is by Wood and Wolfforth at the University of Pennsylvania. And they hypothesized a situation where you've got the sinus node up here, you've got an extra connection between atrium and ventricle. They knew, as Dr. Faddis was talking about from the work of Dr. Sir Kent, that and he was just doing dissections and he saw some stuff that looked like AV nodal tissue off in the lateral right atrial AV junction. Said maybe this is a piece of the conduction system that never developed. Well, they said that's probably what this is. So you're going down the normal electrical system, his bundle, and you're going down this thing and activating some of the ventricle, that's your delta wave. That fit the hypothesis, but the paroxysmal tachycardia, what's that all about? Well, how about you go down the normal system and come back up this pathway with a normal QRS complex? It turns out, bingo, that was right. So it's a hypothesis that fits all the observations, and so you can work backwards from there. And in 1944, another year after their hypothesis, we had some histologic evidence. Here's this little pathway here, and this patient was not known to have Wolf-Parkinson-White, I don't believe, but this was found on a dissection. And there it is right there. And here's from work of pathologic specimens on people who were known to have Wolf-Parkinson-White and died and allowed an autopsy to be performed on their heart. And this was from 1978. And now you can see the atrial muscle here. Here's the mitral valve annulus in dark, mitral valve itself, left ventricle, coronary artery, coronary sinus up here. And this little strand of muscle connects atrium and ventricle where it shouldn't. This is outside the normal conduction system, same thing over here. So there they are, histologic evidence of that, and that turned into therapy. This is what Dr. Faddis was talking about. The first successful surgical division of pathway in somebody who was dying of heart failure because of incessant tachycardia. They had to do something for this guy, and fortunately for everybody, he had a right free wall pathway. Open up the chest, it's just sitting there. You can't see it, but you can tell where it is with mapping, and it's a very easy dissection. The patient was cured. In the middle of this, John P. Boineau, our honoree. He was at this procedure and pivotal in its success. And a lot of groundwork had been done. He took Neil Moore's dog, who came in for a heart murmur. They cathed him. He's got delta waves on the ECG, and Neil talked with John and said, let's do some studies. There was a monkey up in Minnesota that also had pre-excitation. They were waiting for that guy to die and got the heart and had a pathway. Well, this is what we do nowadays. This is what I do. Every once in a while, I get one of these coming along here, WPW, that hasn't been scooped up by the pediatricians, but God bless them. So here we are coming along with a delta wave here, and I turn on power along about in here, and less than a second later, this thing's done. is never going to bother this patient again. It's over. This is a cure. Oh, it's a wonderful thing. You can turn people's lives around. I can tell you stories from the early days that people were just on the sidelines because, oh, you shouldn't do this, shouldn't do that. And it's just a life-changing experience for a lot of folks. So we can quickly, permanently eliminate pre-excitation. Let's look at a timeline along the way. It's an ECG strip there. All this groundwork had been laid by these guys and others, physiology, technology, and biophysical correlation. And it finally comes out here with Waller's first ECG, Einthoven's first experiments, the corrected formula, his use of the string galvanometer, his first published ECG, first abnormal ECGs published, his triangle. Einthoven's all over the place here. Then Lewis comes along, has his 3 books on ECGs in the teens. We get the QT interval correction by Friedricha and Bazet. Now, Bazet has taken over the market, but Friedrich is coming back. It's a little bit more accurate over an unphysiologic range of cycle lengths of tachycardia. An American Pardee describes the ECG findings in myocardial infarction and ischemia. Einthoven shortly thereafter wins the Nobel Prize. The Wolf-Parkinson-White paper comes out in 1930. Wolforth and Wood, in reverse, talk about getting a chest lead and standardizing that. Wilson Central Terminal comes around and his precordial leads. Goldberg comes along and says we can make another set of information from the limb leads, the augmented leads, so AVR, AVL, AVF. Now we have 12 leads, all 12 leads of the ECG. It wasn't until 1954 along in here that the American Heart Association set that standard. So in my lifetime, really, barely. This is the Wood and Wolforth WPW theory. You could get a Holter monitor in 1949. It only weighed 75 pounds, and you could drag it around or a backpack. We know about torsade de pointe. It was described in 1966 by a Frenchman, Dessertin, and we all are monitoring the MCL lead, right, on our telemetry floors. It was described in 1966 by Henry Marriott. Automated ECG interpretation started in about the 1970s. Hein Wellens, another Dutchman, very famous, very, very wonderful person, wrote a pivotal paper on ECG differentiation of VT versus SVT and wide complex tachycardias. And John Gallagher from Duke University had a very famous paper on looking at the delta wave morphology and saying, where's this pathway on an ECG? All this stuff you can discern from an ECG. Now, cardiac arrhythmias, that's my game, Dr. Faddis' game here, Dr. Smith and the rest of the team up here. Atrial fibrillation had been described by an irregularity of the pulse by the ancient Chinese. This is nothing new, but they didn't know what it was all about. They just said it's abnormal. The early tools for investigating arrhythmias consisted of the peripheral pulse, the jugular venous waveform. That's it. We're done. And yet, with these tools, first and second degree AV block, Wenckebach described his periodicity looking at a frog heart. Okay, that's pretty good. I don't think I'd have that insight. Complete heart block, that's pretty easy. Premature complexes, tachycardias, atrial fibrillation, all these were described before there was such a thing as an ECG. With the ECG, wow, we've got a lot of opportunities now. You could take a pair of calipers and an ECG recording and record a lot of things. This is with a single limb lead, a lead 1 or a lead 2, something like that. That's all you got. And these guys are poring over these strips with their calipers and making inferences. So you could describe exactly what's going on with first and second degree AV block. Couldn't tell where it was in the heart until later on. You could talk about complete heart block, bundle branch blocks, premature A's and premature V's, tachycardias of supraventricular and ventricular, atrial fibrillation and flutter. And in modern times, which I talk about starting in about 1982 when I started my fellowship. Now, I'm not going to ask how many were on the planet in 1982. That's too discouraging nowadays, but a few of us still were. Well, since then, I stopped that timeline that I gave you in 1980, because that's when a lot of people thought, okay, we've done this, ECG's over, we'll move on to echocardiograms and caths and stuff like that. Well, a few things have happened since 1980. Indicators of ischemia and infarction, and I'm just talking about a few of these things. Everybody knows about Wellenstein, De Winter sign, of anterior injury, Scarbosa and the ST segment reading and presence of left bundle branch block, ST elevation and AVR more than in lead V1 is an indicator of left main occlusion. Oh, there are minor things, I guess. Cardiomyopathy changes, arrhythmogenic right ventricular dysplasia, cardiomyopathy, Takotsubo syndrome, Yamaguchi sign, apical hypertrophy, indicators of infralateral left ventricular scarring, popularized by the University of Pennsylvania. Arrhythmia-induced cardiomyopathy, that wasn't described. It's a real thing nowadays, especially with atrial fibrillation. It wasn't described until more recently here. Now, we'll talk about these specific indicators of ischemia and infarction. These are worth knowing about. Wellens sign, actually, Wellens was an author, but not the first author of the paper. I don't know if Dr. Dizwan was in on that, but this is named after Wellens because he's a very, very, very famous guy. And this is biphasic T waves in the anterior leads here. You see them here, and there's another form of it where it's a little bit later on in the evolution. It's just very deep symmetric T waves in the anterior leads. And this signifies anterior ischemia and a critical stenosis in the proximal left anterior descending. Now this, you'll get to see these persons in the ER, they'll have this finding here. This is not a ST elevation MI. There's no ST elevation, right? This is not a STEMI. Call off the troops. No, call them in, because this is important to get this guy or this lady fixed pretty quickly, because this is an impending widowmaker here, or widower maker. Similarly, De Winter's sign. You see it here. There's no ST elevation. Well, maybe a little bit in AVR here, but not in contiguous leads. This call off the cath guys. No, 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 call them in. This is bad news here, because this is severe ischemia and this very peak T waves, this very funny ST depression and high peak T wave in the anterior leads mainly. And this is a STEMI equivalent. This is called the cath lab and show how smart you are instead of how refined you are, and so it's not a STEMI. Only seen in a couple % of LAD infarcts. It's also seen in inferior infarction every once in a while, not very commonly. And then the Scarbosa sign, this is knowing that we used to say, well, they got left bundle, it screws up depolarization, screws up repolarization, so the ST segments are what they are, and we can't read a STEMI in presence of left bundle. And Elena Scarbosa comes along and says, let's think about this for a second. Because if you see in a lead with a positive QRS, in left bundle, repolarization is reversed. So you depolarize positive QRS, repolarize with a negative, depressed ST segment and a negative T wave. That's normal for a left bundle. If you don't see that, then that's abnormal, and that could indicate ischemia. So here's ST elevation in a lead where you have a positive QRS complex. Here's ST depression in a lead where you should have a positive T wave because the QRS complex is going in the opposite direction. This is lead V1 of greater than 1 millimeter. And in her original description, it was greater than 5 millimeters of ST elevation in lead V1 or V2. That's an anterior event there. So this is useful stuff. Came out of a large database. It just shook out of a large database. And there's a lot of information mining going on nowadays where there's additional information to be had from what the primary question was. It's usually hypothesis generating. Here it was hypothesis proving. And then the ST elevation in AVR. This is from our paper from back in 2003, where we had a few people who had just isolated ST elevation in AVR. They have some ST depression. It's kind of, they need some treatment. But this is left main badness here. This is really bad news. So if you see this finding, a couple of millimeters in AVR, but not in V1, this is really bad news, and get that person to the cath lab. A few things have happened in arrhythmias since then. The Brugada syndrome, arrhythmogenic right ventricular dysplasia with VT and VF, multiple subtypes of the long QT interval. I think we're up to 12. There had been 2 way back when. Short QT syndrome has been described. All of these are bad actors, VF, VF, VF. You know, this is not just an ECG abnormality. This has some teeth to it. Fragmented QRS, short coupled PVCs resulting in ventricular fibrillation, early repolarization syndromes resulting in VF. Endocardial versus epicardial sources of PVCs and ventricular tachycardia can all be read off the ECG. Ventricular tachycardia rising from the very bottom of where the 4 chambers come together on the bottom of the heart, and where they come together on the top of the heart as well, where the ventricles come together at the outflow tracts, outflow regions. And then variable coupled PVCs. Most PVCs are fixed coupled. If they're variable coupled, that means something. We described that some years ago. A few years ago, I was asked, I've been writing chapters for Brownwald for some time, and I thought, you know, let's just look at lead V1. There's a lot of information to be derived from just this single lead. So here's a normal V1. If you have a long PR and right bundle branch block, that person has conduction system disease. Maybe they'll have heart block, maybe they won't. Maybe they'll have ventricular arrhythmias because that tends to track along with people with sick hearts. So be careful investigate this person. There's the obvious delta wave. There's the Brugada sign, we'll come back to that. Here's the epsilon wave, we've talked about that a little bit. All this in V1. We're not even done yet. Long QT, easy. Short QT, easy. Hypertrophic cardiomyopathy with a big left atrial P wave here, big tall R wave in V1, big deep S wave, repolarization abnormalities. And then the fragmented QRS, popularized by my colleague Mithilesh Das, as an indicator of scarring in the myocardium, disordered propagation through the myocardium, and people who are going to do poorly. All of this is from a lead that did not exist in Einthoven's lifetime. So progress has been made, new stuff has been described, and here we are today. Let's talk about the Brugada syndrome here for a second. The Brugada, in that order, three brothers, described this disorder that had been sitting under our noses for years. It has this funky ECG pattern. People were concerned about an ST elevation infarction. Is it a pulmonary embolus? What is this? This is a person in sinus rhythm and just sitting there minding his own business, sipping on some coffee or something. Oh, let's get excited about it. Our ER calls this, 3 times a day probably, and maybe once a month it's right. But they're really tuned to this thing. So there's the abnormality there. This little right bundle looking thing, and then this lazy descent of the, where's the QRS end, where's the T wave, ST segment? But it's not really right bundle branch block because there's no S wave over here, not a big S wave over in V6. It's not right bundle branch block. This finding may be permanent or it may be transient, it may be heat related, so when people get a fever, they pop up this finding. What's this all about here? It's an inherited abnormality. A lot of Southeast Asians, where it's endemic, young males, the second most common cause of death in young males in Southeast Asia, first being car accidents. The Brugada syndrome is another classic story of people working together, making some observations, and then saying, well, what's this due to? Let's test some hypotheses and figure it out. So it is both depolarization and repolarization abnormalities. This was figured out on animal studies. Charlie Ancelovich, a brilliant electrophysiologist, basic scientist, figured a lot of this out. And quinidine, and has led to innovation in the form of treatment with quinidine, a lost agent nowadays. It's revived with this disorder and some early repolarization syndromes. And catheter ablation. Here's what happens. You have, here's an ECG in lead V2, normal looking ECG. And we have endocardial action potential. This is a single cell stick. And epicardial, they're different. They have different types of myocardium on the ventricular myocardium on the endo, mid, and epi zones. Why it is, I don't know, but it is. I'm sure there's a good design reason there, but it worked quite well, most of us. So they're very similar but different. There's this little notch in the epicardial action potential that's very accentuated compared to the endocardial. In Brugada syndrome, that is really accentuated. So very, very early repolarization, very active transient outward current. So we have this plunge of the action potential down back to 0. And when that happens, there's current leak from the endo to the epi. And with that, you have the Brugada sign. And if it reverberates and goes back out to the epicardium as an action potential, then you have badness. People have ventricular fibrillation. And this will kill you. It's not good. Some VF will stop spontaneously. Quinidine-associated torsade usually stops spontaneously after a few seconds. This stuff may not. This has been parlayed into going onto the outer surface of the right ventricle and doing an ablation. This could be done surgically. We do it with the catheter ablation. Dr. Faddis does this as well and his team. So here are these abnormalities. I'm not going to show you too many intracardiac recordings. This is one set here. This is with a catheter that looks like a flower petal, just sweeping along the surface of the right ventricle. We have these goofball signals here. I saw these first time, I thought, that's artifact, that's motion or something. You move the catheter a centimeter to one side, clean as a whistle. Centimeter to the other side, clean as a whistle. Move it back here, got this stuff. And we can ablate at this and have this, these abnormal signals go away There they are, with ablation on the right ventricular outflow tract, again, epicardially here. There's a pulmonic valve, tricuspid valve over here, the right ventricular body, and just this small patch of tissue up here. And we go from this on an ECG to this, eliminating the Brugada sign. This is remarkable stuff. And this patient, they have a defibrillator, but they're not going to use it anymore. They're not going to have to take quinidine. This is a wonderful thing for these people. Now, it doesn't work on everybody, but it's a pretty good thing when it does. So different applications of the ECG. Wow. And I could go on and on. There's hundreds and hundreds of papers in the last few years about looking at the ECG and finding this abnormality, that abnormality, and turning it into therapy. One thing that we do a lot of is atrial fibrillation ablation. Now, this is a person who's coming along in atrial fibrillation. You can see recordings from the pulmonary vein made from this ring catheter in the situated left inferior pulmonary vein. And that's all interesting stuff, pretty fast. And then we isolate the left inferior pulmonary vein. We know that because the patient goes to sinus rhythm. But the vein doesn't know that. Vein is still in fibrillation. This is a sine qua non of it's coming from that vein there. We don't see this too often, but man, this is a great thing when you see it, and you've just cured this patient. And it's a wonderful thing too. But this is a direct result of looking at the ECG, saying, what's wrong with this picture? How can we turn this into a hypothesis and test it and go forward with it? A lot of derivatives of the ECG over the years, stress testing, golly, we do this all the time. Heart rate variability on Holter monitors, heart rate turbulence, you get all kinds of indices off of those things. What do they mean? Don't necessarily know, but you can do it. Engineers have figured it out. Pacemaker electrocardiography and selection of pacing sites to get the narrowest QRS complex with the resynchronization. Signal averaged ECG, where you add up, record about 200 ECG beats from the same source, and then divide by 200, and you eliminate all the noise. It's a basic science signal processing technique, very standardized. We don't use it too much nowadays. Cardiac mapping, telling where something is coming from by a roving electrode referenced to a stable electrode. Isopotential mapping, Dr. Boineau was very into this in his later years. ST segment mapping, this was done at Duke many, many years ago, trying to figure out how large an infarct was by how the area under the curve of the ST segments. Didn't amount to much back then. At this institution, Dr. Yoram Rudy has been involved in an innovative solution for looking at where arrhythmias arise in atrial or ventricle based on body surface mapping. We saw this ECG before. Pretty nice ECG. Read as sinus tachycardia. I'm not going to say who read it. A famous electrocardiographer, a famous cardiologist read this as sinus tachycardia. But what's wrong with this picture? Does this look like a sinus P wave here? Does it look like a sinus P wave here? No, there's something funny here. In fact, there's more P waves than we thought. And they're over here too. This is not artifact. So this is not sinus tachycardia, but atypical atrial flutter. It's not typical because it doesn't look like typical flutter. All right, what does it look like? Positive P waves at V1, and that funny looking thing in the inferior leads, this is coming from the left atrium. Well, flutter doesn't usually come from the left atrium, but it looks like it's, from experience, it looks like it's rotating around the mitral valve in a clockwise direction in a person who's had atrial fibrillation, because you don't see this outside of people who've had atrial fibrillation ablation or a maze procedure. And it hasn't worked because at least one pulmonary vein is still connected that started this process. So you can infer a lot from this. And probably it's in a middle-aged man, because that's the most folks who have ablation. And he's going along at 120 beats a minute here. His ST segments are fine. He doesn't have any coronary disease. We got all of that from this ECG. And most of us would say, oh, it's fast, sinus tac, next. There's a lot of information here. And there's probably stuff that is still in here that we haven't mined yet. Here's some ECG machinery. I showed you this photo from before. This was, took a 5-man operating crew, weighed only 600 pounds. You could take it around on a delivery truck probably. Well, that's been coned down to this thing, which has a 1-person operating crew, maybe a 0-person in some cases, weighs 2.9 pounds. And this guy is looking at, I could have had that. I got my hands and feet in this bucket of salt, whatever. Or you can take it down to this. Oh. 258 beats a minute. Take a deep breath. You'll be fine. And now he's looking, I could have had that. What am I doing these buckets of salt here? Wow, this is great stuff. The ECG was thought by many to be cute but useless, interesting toy here. A lot of things have gotten that moniker over the years, like the steam engine, radio waves, the copy machine, all this stuff that was rejected originally as being, yeah, interesting, but not very useful. So the future. The utility of the ECG in diagnosis of heart disease is firmly established, but the best may be ahead of us. The ECG is an ideal tool for machine learning. It's highly standardized, there's a lot of them, and you can record them serially and see what outcomes there are as changes occur. AI, especially convolutional neural networks, have been devised and applied to the ECG when it's digitized, and there are practically every month there's a new paper out talking about something, prediction of atrial fibrillation, prediction of heart failure, prediction of hypertrophic cardiomyopathy developing in a person. And you could tell age and sex and race of an individual with these. It's a phenomenal tool for investigation. So what's next? Well, let's talk a little bit about John Pope Boineau here, our honoree. He is one of the pillars of cardiovascular medicine here, and not just cardiology, but cardiovascular medicine, surgery as well. He was educated at Duke, went to Georgetown for his internal medicine, came back to Duke for fellowship. At some heady years back then. Was on faculty at Duke thereafter, went to USC for a couple of years in Los Angeles, and came back to Augusta to work with Lectureship, and then came to WashU here in 1984 and finished his career in 2011. There isn't time or room for accomplishments, but the highlights were the Wolf-Parkinson-White physiology when this was all, it's so easy nowadays in retrospect, but it was unknown back then. These guys are slaving away with hypotheses and testing them and working it out. And the first surgical cure, as I showed you. Mechanisms of atrial fibrillation, he helped devise the Maze procedure that goes on nowadays. The Maze procedure launched into what we do in the cath lab nowadays. All of this is based on some of the work that he did. Hundreds of scholarly works, thousands of trainees, and we're still all learning from him. Here's a paper that he was asked to write for a retrospective on his career, and there's some really nice quotes in here. He says, the most important discovery in biomedical science that can be experimented by any individual is the tension and excitement in the search and discovery. I felt that. A lot of us have felt that, and it's opium. When you get this feeling, you want it again. And it keeps you going late at night working on things. P is less than 0.01. Yes, I was right. And now I can submit my paper. He was on to some stuff with atrial fibrillation. He was very eclectic, but he was on to some stuff with atrial fibrillation. And he was about to publish a paper about some aspect of wavefront propagation. And out came Moritz Alessi and Fick Bonnke with their paper, and he was scooped. And he said, this is another significant lesson. Ideas are multicentric. Other folks can have the same idea. We're all built on a foundation. They're based on previous ideas and are propagating, although an even wavefront of progress. Although they seem new to the observer, any given observer, they are an evolution of which each investigator is, in a sense, only an instrument in the propagation scheme. We're all cogs in the wheel. This knowledge, coupled with the joy of personal discovery, you got to get some satisfaction from that, modifies any disappointment in arriving at the second solution as a little bit late. You're the second guy to report something, nobody accepts that. And then he says, he was talking about propagation, as Dr. Fash was talking about, propagation in abnormal propagation in sick myocardium. I was certain I had convincing evidence of slow myocardial conduction and late activation relating to reentrant arrhythmias. I submitted the first of what were to be several manuscripts on this subject. None were accepted. And a lot of that's because it went against the conventional wisdom. That's not how we understand things. That's what Galileo was up against. Not how we understand things, so it can't be right. Okay. Certainly, he said, I could have written better, but I learned much of the politics of science. That hurts, because it's true. which is a difficult but necessary lesson for the young investigators. So another lesson, you must expect frustration and develop the capacity to live with rejection, but do not be easily discouraged. Young investigators, do not be easily discouraged. This is simply another test that you must pass before being admitted into the select group which occupies the upper atmosphere of your world. So in summary, the ECG is an old, venerable, well-worn tool. It's helped us for 125 years now. Starting as a curiosity, it developed into this ubiquitous tool that is universally recognized as a great aid in diagnosis and treatment of heart disease. It's been a grand story of innovation, investigation, collaboration, and it continues to reveal new secrets, even to today. And I think the most impactful and informational years are yet to come, and who will have that next great idea? Who in this room will have the next great idea? This is not new stuff. This goes back to the ancient Hebrew prophet Zechariah, who said, "Do not despise the day of small beginnings, for the Lord rejoices to see the work begin." We started today with this lady here. You see that she died in 1997, 122 years after birth, the oldest known recorded living human. Here she was. I have to tell you, 117. I got some 60-year-olds. She looks younger than a lot of my 60-year-olds. There she is puffing away. Okay. And then she's got a glass of rum there too. Well, here she is at 122. She's not looking so good. And you know what? She died shortly after that. What's the moral of the story? Don't smoke. Thank you. Should I show the QRs? Okay, here's the QRs.
That was wonderful. Thank you. I think we have some time for questions from audience. Anybody want to comment, ask questions?
That means I've covered everything thoroughly. I don't think so.
Chrissy.
Great presentation. I like the slide on lead V1, and I'm wondering, we see a lot of single lead EKGs. Do you think we can get some of the same insights from lead 1 as we can get from lead V1, and what have you experienced clinically?
Yes, the question is, we saw some examples of a single lead V1 showing us a lot of stuff. Are there other examples of leads where we could derive similar information? Is that your question? Okay, yeah, well, the original ECGs were a single lead, and they got all of this stuff. So I think the answer is yes. I'm not smart enough to have figured this out, but I think the answer is yes. And maybe you could be part of that. Yes, sir.
Well, that was a fantastic talk, and it's really fun to relive my career with you. We started where we started with everybody at Quinity, and now...
We're back.
But I have a question also, and that's about AVR. And, you know, there's my feeling with AVR, being sort of a student of Arthur Moss, that, and Bob Case, is that AVR is really just a reversed other lead. So when you see an ST elevation in an AVR, you're really seeing ST depression.
Yep.
But it's been manipulated to make it look like
Yep.
elevation. And now people say, whoa, a STEMI, but it's really a trick. So what do you think about that?
Yeah, the question is AVR. It is a reversal of what it should be, so it's actually the negative of AVR, but it makes up another point in Einthoven's triangle. You just rotate it around, you got a third 120 degrees apart from the other augmented leads. And the ST elevation in AVR is a real thing, but and a lot of people use it as a V1 cognate, like it's just an extra V1, because it kind of looks at the heart from that corner over there. And again, I think there's more information there than what we have thought. There have been papers written with the title AVR, the Forgotten Lead. It's really good for looking at P waves. We wrote a couple of papers on differentiation of VT versus SVT based on AVR, and just another one coming out, recently came out with pre-excited tachycardias. So I think AVR has a lot of information to it, and you kind of have to think upside down with it, you're right, but it is a very useful lead. Yes, sir.
Got no But we see more non-invasive mapping and that modality being used for our future ablation cases.
Yeah.
Things like that.
The question is, what is the role of non-invasive mapping? And this is with the electrode jacket, and you get a CT scan and correlate anatomy with projected potentials on the surface ECG during an arrhythmia. I think it has a definite role. You all have demonstrated that in spades. It is clunky, and you do have to get a CT scan, and many of us are getting away from any radiation during procedures. The last time I used any fluoroscopy in an SVT or VT ablation or AF ablation, I don't know, been months. I don't put on lead anymore. So having to, and this is in the context of using 2 hours of fluoro in the early days, and now we're begrudging somebody a conservative CT scan. I still don't like radiation in any form. So if it can get less clunky, if we can use an echocardiogram, a 4D echo, or 3 or 4D echo, and get that same information to project and correlate on the surface ECG, then I think we may have something there. But it is a clunky thing at present. No question its utility. And if you have a failed procedure, for instance, you thought you knew where things were, and it turned out not to be, you didn't get the pathway or you didn't get the VT or PVC, line it up and let's see where it's coming from. I think it's a great technique. Yes, sir.
So a beautiful presentation. I wanted to ask you about the AI. You touched on this. So you're right, multiple papers coming out, predictions of things that we didn't think were possible with ECG, such as cardiomyopathy. What do you think the implications are for population screening using AI to detect heart disease that we never could in a way previously?
Yeah, the question is using ECG and AI applications in population screening, yes. I think, we talk about screening athletes with ECGs and with echocardiograms, so that's getting a little bit expensive and low yield. But with the ECG nowadays, I mean, that thing you can cart around for 2 pounds, if you could get, this would make a ton of sense for an insurance company to do. Let's refine your interest so we can refine your premiums, for instance. And maybe we'd want to take you on or we don't want to take you on. Or the government to say, we're going to pay for this, but we want you to, buff up your health a little bit. If you can get this paid for somehow, this is a phenomenal tool. For longitudinal screening, for population screening, and saying, okay, Framingham has done this, they're looking at old ECGs and saying, these folks are going to develop atrial fib, and bingo, that's a high hit rate for those things. So I think, again, that's hypothesis generating. The fact that you go from one thing to an outcome doesn't mean that you can intervene on something, and on what do you intervene? Hard to know, but at least you got a foot in the door. So I think that's a phenomenal application.
Note.
Very good.
Thanks again.